Okay, so let's start the session. This session is about general discussion related to FRCPath Part 1 and Part 2 exam. In case you have any question regarding the exam or any other question that you want to discuss in this half an hour or in our session, you are welcome. Before going to our actual session, I want to discuss the MCQ that we shared in the group 2 days ago regarding uh, acquired hemophilia. I will read the question from the WhatsApp group. A 76-year-old man presented to A&E with extensive bruising and epistaxis. No previous bleeding history. Prothrombin time 14 seconds and APTT 66 seconds, not corrected by mixing study. Factor 8 is 1% and factor um, 8 inhibitor is 18 Bethesda unit. What is the first line treatment? So most of the people selected Novo 7 plus Obizo, and some of the people selected Novo 7 and steroid. So first of all, this case is acquired hemophilia. In acquired hemophilia, the bleeding usually happens later in the age, in the old age. The question also says no previous bleeding history, which means that there is no there is no history of hemophilia or any other bleeding disorder in the past. This is only acquired hemophilia. Then they mentioned to you that APTT is 66 seconds, which did not correct on mixing study, which means this patient has inhibitor. And they have given you the value of inhibitor, 18 Bethesda unit. Now this patient has extensive bruising and epistaxis. So whenever a bleeding patient comes to you with a history of hemophilia or suspected hemophilia, you will give them bypassing agent, either Obizur or Novo 7 to stop the bleeding. Giving this patient Obizur at this stage is useless. This is just a waste of money because you don't know whether maybe this patient has porcine inhibitor. So any Obizur you are giving to this patient is a wastage of money because if this patient has porcine inhibitor, all the Obizur um, will be wasted, will be inhibited by the porcine inhibitor. So if we are thinking about acquired hemophilia in this patient, along with Novo 7 or FIBA, we gave them high doses of steroid and we send blood for porcine inhibitor. It may take an hour or two. After that, once the porcine inhibitor is negative, then we start Obizur in this patient high dose and stop the Novo 7. You can give one factor at a time. Either you have to give Novo 7 or Obizur. Novo 7 is the best choice because it stops bleeding and it is proven in trials. There is a lot of evidence for that as well. Giving Obizur as a first line means you are risking your patient with bleeding and death. If you give Obizur and there is inhibitor, it will not stop bleeding and patient will bleed to death. So always give this patient Novo 7 plus high dose of steroid when you are considering that this patient has acquired hemophilia. Steroids for the inhibitor eradication and the um, Novo 7 to stop the bleed. When you confirm that there is no porcine inhibitor, you will convert to Obizur. Obizur plus steroid will be continued. If there is porcine inhibitor, you will continue with Novo 7 plus steroid till bleeding stop. When bleeding is stopped, you will stop Novo 7 and continue with steroid. Then you will look at the factor 8 level and inhibitor level as well, whether your patient need steroid only or you need to add chemotherapy drug, cyclophosphamide or rituximab. It depends on the factor 8 level and it depends on the factor 8 inhibitor level. If the factor 8 level is less than 1 and inhibitor is above, yeah, and if the inhibitor is above um, 20, it means this is severe acquired hemophilia. This would need steroid plus inhibitor, the rituximab or cyclophosphamide. If the inhibitor level is less than 20, then you can start only with steroid. See the effect in 2 to 3 weeks' time. If there is no benefit, then you can convert that to, uh, or you can add, or you can stop steroid and add rituximab or cyclophosphamide according to your trust policy. So do not start um, Novo 7 and Obizur straight away. This is a blender in the exam. Now you can ask about any question during the related to part 1 and part 2, or any other thing that you want to ask.
Dr. Amir, regarding the blood academy and pathology blood bank, right?
Mhm.
Uh, which is better to submit in?
For the subscription,
Yeah, which is better?
I had done the Path Bank. Path Bank, when I subscribed in the 2023, it has 900 MCQs. So I would say Path Bank is better choice. Go for Path Bank.
Regarding essay, is
Regarding
there any
essay,
source? Oh,
the essay, yes, you can see there are many essays in the Path Bank as well, but it depends on your practice. If you practice them yourself, it will be better than um, than reading the ready-made essays. You need to practice it, then you will learn.
okay. Thank
So
you.
you can see essays in the Path Bank as well. They have given a lot of essays over there, but after reading it, you have to practice yourself.
Sure, sure. Inshallah. Okay, thanks.
And Sharna, do you have any question? Zainab, do you have anything to ask?
No, thanks. I'm listening only.
Only listening. Yeah. I think it was a short notice meeting, so that's why many people did not join. So regarding the essays, uh, which I have checked so far for this week, um, many people are writing in paragraph form, like a complete story. I would advise to write the essay in bullet points and give them heading. If you give them a heading, it will be easy for the examiner to check the answers as well, and the examiner would know at which stage you are. Because in management question, um, they need a sequence. You have addressed patient urgent needs, then after that you have done the clinical assessment of the patient, then consultation with the patient, then treatment options. And if it is a hemostasis patient, they would need prophylaxis heading as well, and then follow up. But if you make one paragraph and mix everything up without any order, um, then the examiners are usually annoyed. Do not use the abbreviation that are not standard. Like last time in the session, we found many abbreviations which we don't know what is this. The only standard abbreviations are for the diseases like CLL, it is standard abbreviation, and for the regimen, like for example RCHOP, BR, that we are discussing in the in the current MCQ in the group. Other than that, do not use any other abbreviation. It is not used in the UK. Then, when you are asked to list the assay, list the differential diagnosis, write the list of differential diagnosis. Do not describe them. For example, in the current question, if it is which was related to transfusion reaction, if it is asking you list the differential diagnosis, you should say just acute hemolytic transfusion reaction, bacterial contamination, wound infection. Do not describe it, although it is less likely given the timing, but should be considered. This is from the current essay. No need to describe it. The question is asking you list it. Or what are the differential diagnosis? 3 or 4 marks, just name them. No need to write in front of it because you have only 40 minutes in the exam for an essay. If you spend a lot of time on one part of the essay or on one essay, your other essays will compromise. And you need to know about uh, practices in the UK. For example, one of the candidate has mentioned uh, that voluntary donors are better than the paid donors in UK. In UK, there is no paid donation. Okay, all the blood donation is voluntary. Uh, there is no system of paid donation here in the UK. Then next thing is in the previous question, people mentioned that I will talk to the wife of the patient or husband of the patient. There is no husband-wife uh, anymore here. The suitable word is partner. I will talk to the partner of the patient. Partner of the patient can be male or it can be female. Male can have a male partner, female can have a female partner. You have to respect the patient wishes here and patient belief. And whenever you are using any chemotherapy drug, you have to consent the patient. For example, in the last question of sickle cell crisis, many people mentioned that I will give this patient hydroxycarbamide. Hydroxycarbamide is not a paracetamol. You take it from the shelf and give it to the patient. It's a chemotherapy drug. You have to consent the patient after explaining risk and benefit associated with hydroxycarbamide, and then uh, you have to give it to the patient. Then uh, most of the people have a tendency to write very long answers. Um, and I assume this long answer would not have been written in 40 minutes. Yes, this is the beginning of practice for autumn 2025 exam. Um, and I hope you will be able to write your answer. You will time yourself and write your answer in 40 minutes. One of the candidate in the last session uh, write a 4 pages answer for the sickle cell crisis question, which is practically not possible in 40 minutes. Then in JPEG, um, there was a book regarding the transfusion, a small book regarding the transfusion. The previous one, if you have the previous PDF, discard it because the previous transfusion PDF book has been removed. Um, it is replaced by Blood Essential. It is a new booklet for the transfusion. Follow that. It has a lot of algorithms. It has a lot of tables as well, and a very colorful book. Use that booklet for the transfusion sessions and for transfusion study. Many people ask about the trials. Uh, Writing a trial in the exam is not necessary, but if you mention the names of the trial, it will carry a positive marks. Um, the examiner will be happy about that, and they can give you some extra points as well. But you are not required to write the detail of the uh, trial. You can only give a reference that according to this trial, and write the sentence, or you can say different trials in, for example, CLL. Then you can mention one or two trials. Or if this is a hemostasis question, um, and you are talking about cancer-associated thrombosis, you can mention names of the few trial. Description of the trial is not required in the exam. It just carries a positive point in the exam, so it is better. You should know about the updates in the for the exam. In the last question, which was about sickle cell disease, many people mention that the updates in a sickle cell disease are Crezan, Zilumab, or Voxelotor to be used in sickle cell disease. These two drugs have been removed uh, from UK. We do not use them anymore in UK um, because of multiple deaths related to Voxelotor and reduced efficacy for the Crezan Lizumab. We are not using it anymore. They have been removed from the UK market last year. So do not write that Voxelotor is still in use or Lizumab is still in use. No, they have been removed. There is a new therapy, uh, stem cell transplant in the form of Casgevy, approved recently in the UK. You can mention that. And previously in sickle cell disease, we used to use uh, red cell, which is less than 10 days old for transfusion, less than 7 days old for exchange transfusion. That age cap has been removed in UK as well. You can use any age group, blood for sickle cell disease, for transfusion, top of transfusion, or for exchange transfusion. There is no issue with that. If there is anything in your mind that is coming up, till we have few minutes, you can ask.
Again, Dr. Amr, you said no age restriction regarding top-up transfusion?
In sickle cell disease, and
Yes.
previously in sickle cell disease, we used to give them less than 7 days old blood or less than 10 days old blood for top up or exchange transfusion in sickle cell disease. Now that has been removed.
Okay. Got it. Thank you.
Yeah. So you can use any age group in the uh, sickle cell disease or in the exchange transfusion or in the top up. No issue with that.
Okay.
The other MSQ in the group اللي هي اللي هو cold autoimmune اللي هو تشاد disease.
Which one?
There is another MCQ in the group. The answer was rituximab was تشاد disease. يعني give base that patient is lymphoproliferative.
Yeah.
Then the answer.
So the question was, a 56-year-old man presented with discolored fingers, which means Raynaud phenomena, cyanosis. Bloods 109, white cell count 11, platelet 154. Blood film shows red cell agglutination and plasmacytoid lymphocytes. BMAT, the bone marrow biopsy, confirmed low-level lymphoplasmacytic disorder, low-level LPD. So this is a classic presentation of chart patient, cold hemagglutinin disease. They have agglutinin and lead to narrowing of the blood vessels, causing Raynaud phenomena in the extremities, and they are usually associated with LPL disease. So this is a secondary chart. So in secondary chart, you will give these patients um, rituximab. Uh, Steroid usually do not work in the chart. So steroid is not the first line in chart diseases. It is the chemotherapy which we use always as a first line in chart. Steroid you will only give if there is significant hemolysis going on in the child as well. This patient hemoglobin is 109. He is maintaining the uh, hemoglobin. So because he is developing Raynaud phenomena, which can lead to ischemia as well if it gets severe, then we have to give this patient rituximab. And rituximab will help the low-level lymphoplasmacytic disease as well. It will help the um, charts as well. Did you get the point or not?
Yes, I got. Thank you.
Then the last question that was posted by the admin is, a 65-year-old man was referred to hematology due to B symptoms. So B symptoms mean uh, night sweats, weight loss, lymphadenopathy, low appetite. This is B symptom. Background of hypertension, blood shows hemoglobin 98, white cell count 14, platelet 149, high LDH, CT shows stage 4 disease, lymph node biopsy shows CD5 negative, 10 positive, 19 positive, 20 positive, BCL2 is positive, and MYC88 is positive as well. This will be mid 88, not MYC 88. So what is the suitable treatment? So what do you think is this disease first of all?
هو الام واي دي 88 ده في الليمفوبلازمستيك ليمفوما، مش ده الليمفوبلازمستيك؟
Which one?
ام واي دي 88 as mutation not here. ام واي دي 88 في الليمفوبلازمستيك والفولدنشتورم. I am not telling about this question generally. MYD 88 mutation في
Mid
الليمفوبلازم.
88 Mid 88 is present in multiple diseases. It's not necessary to be present in Waldenstrom.
Okay.
You can have mid 88 in different diseases.
Here BCL2 positive, maybe follicular. I'm not sure.
DLBCL is the most likely diagnosis here. Okay or not okay?
What, diffuse large B-cell lymphoma. Okay.
Yes, this is a diffuse large B-cell lymphoma in the patient. What do you think? What regimen should I give this patient? among the options that has been posted in the group. This patient has a background of hypertension on. So you need to calculate the IPI score for this particular patient. If the IPI score is high, about 2, then you have a new regimen in UK, Polar Archer. If the IPI score is high, 2 or more than 3, and the patient is young, like 50, less than 50 or less than 55, for example, and no previous comorbidities, you can give them an intensive chemotherapy regimen, Orthodox M, Orthodox RIVAC, or ARDA-EPO. But if your patient is not that fit, our current patient in the MCQ was above 60, you can offer them Polar Orchard if the IPI score is about 2, and if the IPI score is less than 2, then you can give them Orchard as well. The guidelines for DLBCL have changed recently. So age was above 60. This is 1 point. High LDH. This is second point. He has stage 4 disease. This is a third point. His IPI is about 2. You can give this patient polatuzumab based chemotherapy, Pola Archer. And then if this was an essay case, then you would calculate the CNS IPI for this patient as well. Maybe the CNS IPI is more than 4, then he would need methotrexate as a CNS prophylaxis. And the route of CNS prophylaxis depends on whether your patient renal function is okay or not. If your patient renal function is normal, you can give them IV methotrexate, high dose methotrexate. If the renal function is bad, you can give your patient uh, the intrathecal based methotrexate. There are other indications of CNS prophylaxis as well. For example, if you have 2 or more than 2 extranodal sites are involved, or if you have adrenal or renal involvement, if you have intravascular disease, these are a few other indications for the CNS IPA, CNS prophylaxis. So follicular lymphoma is 1418. It is not associated with mid 88. I think it was a misspelling in the question. It is mid 88, not MIC 88. Any other question?
Dr. Amir, you mean that it is not follicular because of med 88 is positive here?
Yes. Mid 88
Oh,
is positive and 43 is negative.
okay.
Any other question?
Thank you.
Thank you, Dr. Amir. Thank you.
We have discussed few MCQs and about the assays as well. The common mistakes that the people do in the essays. If there is anything else, you can ask. Um, Otherwise, we can wind up the session then.
Thank you.
Thanks
Okay.
a lot, Dr. Amir. Thank you very much.
We will have our routine session tomorrow regarding the transfusion, because this is a transfusion week. And see you tomorrow.
إن شاء الله.